if they're not drained out through the skin, then they are taken up through the lymphatic system. Notice, as we mentioned before, they are a very large percentage of total white blood cells, and they're the first line of defense. Now, also keep in mind that if we use them all up, we're going to be calling up macrophages, but we're also going to be calling up the bands, which are immature neutrophils. Okay, eosinophils. These again, they are phagocytotic, and they are very. Remember, always think parasites. When you think of eosinophils, always think parasites. You may see the question on your test. If parasites are involved, or if eosinophil is the topic, they are particularly useful against. And we also see them in allergies. You also see a very high eosinophil count often in a patient who is allergic. And they also contain those mediators, the prostaglandins, the leukotrienes, and so on and so forth. They will degranulate and release those. Okay, here are the macrophages, also known as monocytes. These are the largest white blood cells. They live for months to years, and they will migrate slowly to the site. And if we have an elevated count of macrophages or monocytes, and the inflammation has been going on very long, this is a sign of chronic inflammation. Okay? Notice it's a very small portion of the white blood cells, but very, very important. And what do they do? Okay, there's a sequence. They do margination, which is where they attach to the wall of the blood vessel, and then they have emigration, where they go ahead and leak out of the blood vessel and into the tissue, and they attack the whatever the dangerous material is. What do phagocytes do? They're phagocytotic. They eat things. They have vacuoles inside the cytoplasm, inside the cells. So they will eat the bacteria, as you saw in the book. The bacteria or the debris, whatever it is, will go inside, and then the macrophage has a number of these vacuoles in there. One of them is called it contains a poisonous material that or a very dramatic pH, and the bacteria will be attached to that vacuole, and the bacteria will be killed by that poison or by that change in pH. So they're very, very resourceful in terms of their ability to deal with invading bacteria or debris. And one thing I want to give you a little heads up here. We will consider this a white blood cell. Imagine that it has an antibody attached to it. Okay, an antibody is just kind of shaped like a Y type of thing, and it will oftentimes contain a piece of just a memory of an antigen of a bacteria or something that is foreign to the body, and that will be what we call a sensitized white blood cell. It is sensitized by the antibodies to a particular antigen, and if that antigen, like let's say that it was sensitized to staph, for example. So if staph came from, which is typically present on the outside of the body, if staph was driven inside, a white blood cell that had an antibody attached to it that recognizes staph would respond to that immediately. So that's just something to kind of think ahead as we look ahead to the next unit that we'll be talking about in immunity. Okay, the lymphocytes. These are cells of the immune response. Okay, now notice that we talked about these other cells over here, and these are basically your lymphocytes, the B cells and the T cells. Remember that the neutrophils, the macrophages, and the eosinophils, these are all called leukocytes, or white blood cells. The acquired immune system cells are lymphocytes. Okay, and there's a couple of categories of these that are really important. They are T cells and B cells, very important. The B cells produce antibodies. T cells, and especially you have T killer cells or cytotoxic cells, cytotoxic T cells. You have T helper cells. The T helper cells are sort of the conductors, the coordinators of this whole system. By the way, I should go back up here to eosinophils and point out something very important about the function of eosinophils. They control the inflammatory response. One of the functions of eosinophils, once they arrive on the scene, if the inflammation is under control and the threat is being neutralized, we have to turn this inflammation off. And one of the functions of eosinophils basically is to turn the inflammation off. So they have a very important role in that sense. Just as if you go back to the stress response, one of the functions of the alpha-2 receptors is to turn off the stress response. Well, the eosinophils kind of have a similar function in the inflammatory response. Okay, just remember these types of cells. We're going to talk a lot more about them as we look ahead to the next chapter. Okay, question for you: which leukocytes participate in the acute inflammatory response? Remember, that's the immediate inflammation response. Well, do neutrophils? Absolutely. Do monocytes? No, they come up a little bit later. They will be involved, but not just right away, and also the eosinophils. So the answer that I would choose would be A and C here. Cell-derived mediators of inflammation, the arachidonic acid that we talked about, the prostaglandins and the leukotrienes, cytokines, nitric oxide, we'll talk about its function. Also platelet activating factor. Remember that we've had an injury to the tissue, and one of the things that we have to take care of is we have to start repairing that injury, start creating a clot and creating eventually creating a healing scar and scarring process, and we'll do that with the platelet activating factor. Okay. Now, cytokines are and basically this just means cell action. Kine means kinetic, cyto means cell, and these are compounds. These are chemicals. They are not cells. It's just a compound that is secreted by a cell. Pyrogenic means that this is something that increases fever or increases body temperature. The IL-1 is produced by macrophages in response to tissue injury. So the macrophages will secrete IL-1 or interleukin-1, and the action of it is to go to the hypothalamus in the brain and turn up the body temperature a little bit. Go to the liver and activate the release of plasma proteins, which we'll talk about. Also, the IL-1 further will keep sending a message. We need more neutrophils. We need more neutrophils, because remember, macrophages are they're very big and powerful, but they're relatively small in number. So we need to keep bringing up the neutrophils throughout this inflammatory process. And also, IL-1 will start to stimulate the B cells. Okay, so now here we have interleukin-1. This is something that is going to start connecting the innate immune system and inflammation. It's going to start making that connection and calling up elements of the acquired immune system. Okay, and you can read about the details about how all that does and what the benefit is of increasing body temperature. Because remember that we are miserable when we run a fever of another degree or two, but also bacteria is very miserable. So that's one of the reasons that we want to increase the fever a little bit, is that it will help hopefully in our fight against invading bacteria. Now, another pyrogenic cytokine is tumor necrosis factor. Again, it's produced by actually a number of cells, and they're released oftentimes in response to the gram-negative cell wall. Remember that a gram-negative cell contains certain compounds within its cell wall, and tumor necrosis factor recognizes that. It also is a chemotaxin factor for neutrophils. So again, if TNF is being produced, it continues to send that message. We need more neutrophils, because remember that if you have a growing colonization, let's say that you have that splinter, the splinter came in, and now you have a colony of staph or something that's growing in your skin, we're going to have to continue to call up those neutrophils, to continue to keep eating away at that and walling it off. So all of these downstream mediators, like tumor necrosis factor, will continue to stimulate and call up for more neutrophils. Okay? And it also, again, stimulates the T cells and the B cells and so forth. Okay? And also it has it inhibits tumorigenesis, or the start of tumors, and it can cause apoptosis or cell death. Okay? Nitric oxide, very interesting compound. It is a vasodilator, and it regulates binding and release of oxygen to hemoglobin, and therefore it helps control the amount of oxygen that reaches the mitochondria by controlling the binding and release of oxygen. Because remember, hemoglobin is a component of red blood cells that carries oxygen throughout the bloodstream. Nitric oxide is also very deadly to parasites, and it stimulates production of new mitochondria to keep the powerhouses of the cells going. Nitric oxide is but it's highly present in inflammation. That's the important thing. And somebody, for example, let's say they have controlled asthma, but they come in with an exacerbation of their asthma. One of the tests that the doctor might run is, or the nurse practitioner, would be a nitric oxide test. And if nitric oxide is detected at above a certain threshold, that can be a signal that inflammation is actively going on. Mediators of inflammation, again, the complement system, clotting system, and kinin system. These travel in the blood, and they're not really cells, they're just component little pieces of protein, essentially, and we'll talk about what they do. Very, very important functions to play. The complement system is activated by an antigen-antibody response. It's released. The products are released in the presence of the bacteria that stimulates the antibody response, and it also will help to activate the clotting and kinin systems. We'll talk about them in a moment. Now, the really important functions of complement systems are four. They help to further the vasodilation. Remember, when we dilate the blood vessel, we also make it more leaky, and this enables the neutrophils and the macrophages to spill out of there and get into the tissue where the injury has occurred. They will also opsonize bacteria. And what that means is they will essentially put a sign, they will signal this is a bacteria. And they also help to agglutinate and glom bacteria together. And then that creates a signal that for macrophages that can come in and eat that opsonized bacteria. They will also attract phagocytes. They have that chemotaxic effect to draw in the neutrophils and the macrophages. And they also have something which is called a MAC attack, a membrane attack complex, and it's literally like a drill. If you'll see that they will kind of plant themselves on the top of the membrane of the bacteria, and they literally just cause that membrane to explode, and the bacterial cell explodes and dies. Those are the four basic functions of the complement system. How do we opsonize it? Well, here's an example. They will coat the bacteria and make the bacteria more obvious to a macrophage. And Professor Unruh uses the analogy of covering the bacteria with chocolate, making them attractive, and that's one of the important functions of the complement system. And there's a couple of different cascades. This will show you the different cascades. There's the classical, there's the alternate. But you'll see in every case, they basically will have that chemotaxic effect. They will have that opsonization, and they will have the MAC attack. And these Sieve 3, 4, 2, and all these numbers, these are just parts of that system. These are types of different types of proteins that are part of this system. But what you really need to know about them, the end result: vasodilation, opsonization, chemotaxics, and the membrane attack system. Now the clotting system. The clotting system basically starts to create a mesh and the whole idea of the clot is to stop any blood flow and to start the healing process. And we need platelets involved, fibrin involved, etc. And there's an entire process of formation of clotting, and we'll talk about that in a moment. Okay, now just remember again that at the first injury, the first thing that happens is the vessel will spasm shut, and then it begins to open up, and as it opens up, this will allow these components of the clotting system to start to come into the scene. Platelets are not true cells; they're just fragments of cells. But they will be called up to start creating a plug at the site of the injury. Now we have something that's called platelet activating factor, or PAF, and this is activated when the vessel walls, when the wall of a capillary is injured. PAF is released from that damaged tissue, and the platelet activating factor is just what it sounds like. It begins to activate and call up. It calls the platelets to the scene of the injury. Okay. Now we can again take a look and see what all is involved here. And again, you just see the platelets coming to the site of the injury, and you can read all the details. And also serotonin is a compound that's involved in this process as well. Platelet plug formation. Again, we activate the clotting factors in the plasma, and this forms a product called fibrin. Please remember fibrin. And fibrin will basically trap red blood cells. This is that mesh that the red blood cells start to get caught in, and then this begins to create a clot. Okay? And again, the damaged tissues release a protein called tissue factor, and it binds with factor 7, which is one of the clotting factors. And it will then activate factor 9, which then creates this sequence of clotting and forming a clot. Okay. Now there are two pathways of blood coagulation, and the important thing is that they both will come together at what's known as factor X, and these are factors in the process of forming, taking liquid blood and forming a hard clot out of it. Okay, there's the extrinsic, which is a very fast way. It's a kind of a shortcut to form a clot, a very fast clot, and then the intrinsic way, which is a little bit slower pathway. Okay, and the clotting system, again, it will call up the neutrophils, it will increase permeability, and it will enhance the effects of bradykinin that we'll talk about in a moment. Now, notice, here's the extrinsic factor and the intrinsic. Now, notice the extrinsic is a little bit faster. It goes from factor 12, or from factor 7 right over to factor 10, and then right down to creating the fibrin. Okay, whereas the intrinsic has to go through factor 12, factor 11, factor 9, and then factor 8, and then to factor 10, and then it goes down the system. So, but both of these, and you can remember the this TENNT acronym here: 12, 11, 9, 8, and then back to 10, and then you're on down the line with the forming the clot. The intrinsic system, it's going to take 5 to 10 minutes. The extrinsic system will only take a second or two. So when you see a small injury to your skin, for example, and you will see that clot that is formed very quickly, that's going to be from the extrinsic system, and then the intrinsic system will come along and form a more complex response. The idea of the extrinsic is to quickly wall off the loss of blood. Okay, the bradykinin system. Bradykinin is or the kinin system. It's actually an entire system, but bradykinin is the primary plasma protein in the system, and it will cause vasodilation of the arteries. It will stimulate the prostaglandins, which again, remember that they are responsible for pain and more and activation of the clotting. It will cause smooth muscle contractions, increase the permeability of the capillary, and it will also call up, or it's also chemotaxic. One thing that's important to know is that the bradykinin, or the kinin system, is also, notice all of this, what does that amount to? Swelling. And the kinin system, notice that histamine is not involved here. So we have two basic systems of swelling, one being the histamine system, the other one being the kinin system. We've known about histamine for decades. We're just now beginning to appreciate the kinin system. And sometimes a patient will be given an antihistamine or a steroid and they don't respond, the swelling doesn't go down. That's a good indication that their swelling is really being driven by the bradykinin system, and that's what we call angioedema. And you may see that. We're not going to get in too deeply into that in this class, but it's just something to keep in mind in the back of your mind. And those patients, if they have severe swelling from it, it can be life-threatening, and I really think some facilities are barely even familiar with swelling related to the kinin system, and they can be some of them have never seen it before. And giving a patient a kinin reversing product is very expensive. We have a lot of steroids and we have a lot of antihistamines to take care of histamine, but we have a relatively small storage system for kinin, anti-kinin products, and they can be very expensive to give somebody, but they can be the only thing that can save their life. Okay. You need to know that kinins are a response to triggered by the release of collagen proteins when a blood vessel wall is injured. So again, you see that injury to the blood vessel itself, and the collagen, which is a major component of that tissue, will be released, and that will start to call up the kinin system. And the result is vasodilation and leakiness and pain. Okay. How do we control these systems? Okay. Well, we talked about eosinophils and neutrophils. Once we've had enough inflammation and it's gotten the job done for us, eosinophils and then also neutrophils can start to participate in the cleanup. You know, saying, okay, we can turn this down now, we have enough response, and that's basically how the system is turned off. Now, this is just a review of what happens with these components. We have an injury to the cell, and that's going to cause those mast cells to degranulate. It's going to activate the complement and the clotting kinin systems, and we're also going to get the release of the cellular components like the histamine, like the chemotaxic factors, like the arachidonic acid, like the interleukins, the tumor necrosis factor, and on and on and on. All of these things are going to be going on simultaneously, and the result is going to be redness and heat, swelling, the pus that's going to accumulate, or the exudate. We're going to start to get clotting, and we're going to have a sensitization of those nociceptors, and we're going to have increased pain. And pain in that sort just serves a purpose, because it gives us a warning that there is an injury. Okay, now if we have systemic inflammation, if the inflammation is all over the body, what are we going to notice? Well, one of the things we're going to notice is fever. And remember, fever will be activated by a cytokine, and one of the most important cytokines to activate, those are those pyrogenic cytokines like interleukin-1, IL-1. And they will go to the regulatory center in the hypothalamus and basically say to turn up the temperature. The other thing that we're going to see is a significant increase in white blood cells. So, for example, let's say I get a little splinter here in my left arm. That's not going to cause any dramatic increase in my white blood cells. But if I have a septic condition, if I have bacteria circulating throughout my blood, I'm going to have a lot of white blood cells. Now, the normal count of white blood cells is somewhere between 4 to 10,000 per unit of blood. But in the case of what we have what's called leukocytosis, or a increase in white blood cells, we can see it going up to 15, 20,000. Now, in some blood diseases, blood cancers and so forth, you can see this going up into the 40s, 50,000, very, very high. In response to a blood cancer, for example. The other thing that you're going to see in the leukocytosis, you're going to see more immature neutrophils or bands. Those are typically just not even 1% of white blood cells, but they can go up to 5, 10, 15% if you have a very important inflammatory process. Also, the lymphadenitis. The lymph nodes will become swollen and painful to palpation. Okay, now what is the symptoms of chronic inflammation? This is inflammation that goes on time and time again, just constantly. And one of the things I want you to think about is the macrophage activity, the macrophages. And keep in mind, when the macrophages come in, they eat the bacteria or the debris or whatever it is. But they are not the most perfect eaters. They're also going to be eating a little bit of good tissue. Well, imagine that you have inflammation going on all the time, just constantly. Well, you're going to start to have good tissue being eaten by the immune system, essentially. And obviously that's going to be long-term tissue damage that you're going to get because of the chronic inflammation. And the wounds will not heal correctly. You will get persistent signs. You will have persistent swelling. For example, you'll have somebody that has rheumatoid arthritis of the knee. They're going to have swollen joints and the like. Okay, so these are just things to keep in mind in chronic inflammation. Okay, how can we detect inflammation? Well, we can run that complete blood count. What are we going to see? Well, we're going to see elevated. We're going to see the leukocytosis. The white blood counts will be significantly above 10,000. We're going to see if it's a really significant inflammation, we may see the bands coming up. We will also see an increase in what's called the erythrocyte sed rate, or the ESR. We will culture the wound if we do it correctly, and we will find the presence of bacteria. And then we can run what's called a sensitivity analysis and find out what types of medication that bacteria is going to respond to. We can also do a serum immune complex. We can actually run a blood test and check for levels of immunoglobulin G, A, M, and E. We can also run and check immunity against a very common bacteria, like the one most commonly used would be strep pneumonia. There's 23 different serotypes of strep pneumonia, and we can check to see how the patient's immune system works, if it's working well or not. Also, of course, we will have the vital signs. We will have fever. We will have, depending on their response, if they're in shock, they will be hypotensive. If they're in significant pain, they might be tachycardic. So, but we put all of these signs together and of course in the assessment you're going to see the swelling, the redness, the presence of depending on where the inflammation is, you'll see the pus and so forth. That will all give you that assessment for inflammation. Okay, Remember, this is a review, 3 basic mechanisms: vasoconstriction at first, and then we dilate. And when we dilate, we open up the blood vessels so things can move, these components can move into the tissue, and that causes the swelling. And then, again, just a review, a splinter breaks the skin and it's going to trigger a non-specific response. Remember, that we're not going to call up a bunch of antibodies right off the bat. We're just going to call up the innate system. The barrier has been broken, and so now we're at that level 2, or the inflammatory response. Okay, so here's the splinter area. The bacteria is moving in. There's your mast cells, and by now you're probably saying, hey, I got this. There's your mast cells. They're in the tissue, and they're going to start to degranulate to respond to this. And of course, here you have your capillary where you have your neutrophils, and they're going to start leaking out into this area. And remember, very importantly, they're going to start walling that off. We don't want the bacteria to start growing in the skin. We want to have that limited, and so we will bring in these components of the inflammation system to take care of them. Okay, there you see the mast cells degranulating. They're releasing the histamine. The histamine is going to reach the capillary and start it dilating and leaking. And I have an attack cat here. I don't know if you can see him. He's going to be coming into the picture. He's not uninvited, but okay. So there he is. Okay, so. Again, now you can see the capillary is starting to swell, and the histamine is, again, starting to create that vasodilation, and we're starting to get the complement system is coming in, and the phagocytes are starting to come in. And those are starting to line up on the edge. They're starting that pavementation, and then they're going to start migrating out to the scene of the injury. And here they're starting to leak out, and you can see the phagocytes are moving out. They're leaking out through the wall of the blood vessel, and they're going to the scene of the injury. And there's your complements coming in. Remember, the complements have 4 functions. They're going to start gluing or opsonizing the bacteria, making it very obvious to the phagocytes. They're going to start calling up more phagocytes. And they're going to help with the vasodilation. And they can also have the MAC attack and start directly attacking that bacteria. So you can see you have multiple weapons in the immune system that are responding to this injury. Okay. Now, the bacteria has all been cleaned out. We're going to stop the signaling. We now no longer need the phagocytes to respond, and now the tissue is going to start to heal, and now we have the healing of the wound process. Okay, and it's the final step in inflammation, and you need to know these phases. They could be on the test. Resolution is proliferation of normal cells, so the normal cells will start to return. The repair is replacing the